Good afternoon, everybody. I hope everybody's doing well. Thank you for joining us all today for this webinar on understanding the pathway to primary care first. My name is Stephanie Kovalik. I'm the Chief Strategy Officer for Sage Growth Partners, and I am very honored to be here with our panelists. I think you're going to really enjoy listening to them and learning from them. Today we have Alyssa Dahl. Alyssa is the Senior Director of Advanced Analytics at DataGen. She's an industry leader in modeling and interpreting current key payments and policy issues impacting value-based revenue. Over the past 8 years, Alyssa has supported healthcare providers across the nation to maximize their potential for success in alternative payment arrangements and population health initiatives. Alyssa brings clients new insights thanks to her background in epidemiology and her expertise in Medicare payment policy and quality measurement techniques. Alyssa received a Bachelor of Science degree in biochemistry from Loyola University of Maryland and a Master of Public Health degree in epidemiology from the State University of New York at Albany, where she is currently a PhD candidate. We also have Mandi Diamond. Mandi is the Senior Practice Transformation Advisor at DataGen, and Mandi brings more than 19 years of hands-on clinical project management and hands-on information technology experience. She joined Haney's in 2015, and Mandi has guided countless practices of varying sizes, specialties, and organizational structures through their patient-centered medical home transformation journey. Mandi infuses project management and change management interactions with medical practice teams to ensure seamless adoption and implementation of new workflows, policies, and quality initiatives. She's a trusted source and agile in her approach based on practice expectations and learning styles, employing on-site and virtual collaborations to guarantee success in bending cost trends and increasing patient outcomes. And we have Teresa Dreyer. Teresa is the value-based care leader at the Association of American Medical Colleges, where she facilitates initiatives for over 40 academic medical centers. Teresa identifies opportunities for improvement to care or policy advocates for federal policy changes to promote the highest quality of care and services as the subject matter expert on value-based care policies. She holds a master's degree in public health and a bachelor's degree from the University of Michigan. Again, I am super honored to be here with this group, and let's take a look at the agenda. So today we're going to talk through these things, right? We're going to go through the primary care evolution, an introduction to primary care first, some considerations for participation and how you might prepare a roadmap, right, to take advantage and participate. Then we'll move to a question and answer session where we'll get to hear from you guys. What are you interested in learning about and hearing from our panelists? And then any next steps or and any additional questions that we have. Before we move on, though, I have a few questions for you. This is going to help give us a sense for who our audience is. So let's start to take a look at those questions. The first question we have, and you'll see the poll pop up, is what best describes your interest in primary care first? Give you a couple of minutes. And then move on to question 2. The second question, which you should see a poll pop up any minute here, is how many Medicare fee-for-service beneficiaries do you estimate will be attributed for your organization per year? We'll give this one a minute, and then we'll move on to poll question number 3. And the third polling question is, what is your practice's prior experience in primary care innovation models? And so now we'll move on to the core of our webinar today, which is really talking about primary care first and the kind of evolution toward that and where we are. So it's really interesting. I'm a big fan of value-based care and value-based payment models, and know it's challenging in today's environment and in today's world, and really happy to see primary care really get the attention it deserves as we're looking for payment reform and healthcare delivery reform. So it's a super exciting webinar, and I'm sure you're going to get a lot out of the discussion. I'm going to turn it over to Alyssa right now, and she's going to bring you through the first part of the agenda. Alyssa?
Great, thank you, Stephanie. Hello, and thank you all for joining us today for this discussion on primary care first. So for some brief level setting, I'm going to touch on the evolution of primary care models to drive value-based care over the past 10 years in the Medicare program. And the primary care first model is really the latest advancement from CMMI to strengthen the role of primary care in the health system. But if we take a look back, we can see other programs and models that came before it, such as patient-centered medical homes, which began recognition in 2008, the Comprehensive Primary Care Initiative, which began in 2012, followed by the Comprehensive Primary Care Plus model in 2017. And most recently, we have Primary Care First, where the first cohort officially went at risk in January of this year. And a common thread among each of these programs has been to make a commitment to continuous quality improvement and to take a patient-centered approach to primary care. Next slide. Starting with the patient-centered medical home, this is a delivery model built on the relationship between patients and their providers and the coordination of their care across the continuum. Key concept areas of the patient-centered medical home include team-based care, care coordination, quality improvement, knowing and managing your patients, having case management, and also promoting access and continuity for the population. While the medical home concept dates back to the early 2000s, the first recognition program for PCMH was introduced in 2008 by NCQA, which is the National Committee for Quality Assurance. And today there are over 13,000 practices with PCMH recognition. And it's also, I think, noteworthy to note just the undertaking that PCMH is with all of the specific workflows and policies that these organizations put into place to meet the concept areas and the other electives that they have undertaken, and the rigorous documentation and reporting, which really has helped them set up for the future value-based payment for their practices. Next slide. So next in the evolution of primary care models comes the Comprehensive Primary Care Initiative, which was a 4-year model that ran from 2012 to 2016 to really continue that effort to strengthen primary care. It was then preceded by the Comprehensive Primary Care Plus model, which launched in 2017 and will run for 5 years. And these models have been tested in specific regions throughout the country and include elements related to practice redesign, such as having risk stratified case management, as well as financial support in the form of monthly care management payments per beneficiary, and the opportunity to earn performance-based payment incentives based on measures related to patient experience, quality, and utilization. Next slide. So this brings us now to the present with Primary Care First, being that latest and next advancement in primary care models to be tested by CMMI. Primary Care First will run for 5 years for each cohort, with cohort 1 already at risk as of January 2021, and cohort 2 to begin going at risk in January 2022. And then just a couple of things noted here. Primary Care First is going to aim to reward practices for outcomes. There is special attention that the model aims to give towards practices who have complex populations that need better coordination, having some greater data transparency than prior models, and also lessening some of the documentation and the burden that that brings to providers. Next slide. And we'll get a little bit more into talking about Primary Care First and key components of the models, but I would say this is also just a bird's eye view of the program, and really there is a lot of nuance and complexity of the program that's worth exploring further than what I'll note on here. So with some similarity to its predecessor models and initiatives, these are the goals that CMS has laid out for primary care first. So practices will work to improve patient experience and outcomes, increase accessibility to care, provide comprehensive care coordination, enhancement of the doctor-patient relationship and really putting that at the forefront of their care plan, reduction in total cost of care to the Medicare program, and also that focus on chronic and complex patients with care fragmentation. Next slide. There are numerous participation requirements for practices interested in the program. Primary care practices are eligible if they have clinicians in internal and general medicine, geriatrics, family medicine, or hospice and palliative care. These practices should have at least 125 attributed Medicare fee-for-service lives to participate in the program and must be located in one of the PCF eligible regions, of which there are 26 in total. Practices also have to predominantly bill for primary care services, which is measured as 50% of their revenue. They need certified electronic health record technology and also health information exchange connectivity. They should have advanced primary care delivery capabilities, an example of this being having 24/7 access to a provider. And these providers should also have demonstrated experience in value-based payment arrangements to be able to take this next step in a program like Primary Care First. Next slide. So if we think of who is eligible, there's a nice map here from CMS displaying the 26 regions where practices are eligible to participate. Some of these regions are represented by entire states, whereas others are defined greater metropolitan areas, which you'll see noted as stars on the map. Regions currently in the CPC Plus model have eligibility for Primary Care First, as well as several additional regions that CMS has added for this program. And a noteworthy change for Cohort 2 is that any primary care practice with an eligible region, within an eligible region may now apply, and Cohort 2 is no longer restricted to practices with prior CPC Plus participation. So it's a chance for more providers to begin the model for that second cohort. Next slide. And I just want to note a couple of the key model features. So there are several ways for providers to participate in PCF. There is the general population model, a seriously ill population component, and also a hybrid approach where providers will manage the care of patients that would fall in both populations. You'll note the seriously illness population component is starred because currently that component, which would have gone live and at risk as of April 1st of this year, has been postponed and is currently under further review by CMS. In terms of beneficiary alignment for the program, that happens for a practice in two ways, either through voluntary election of a primary care provider by the beneficiary through Medicare.gov, or alignment happens through an attribution-based approach using 2 years of claims data for applicable primary care visits. The payment methodology includes a population-based payment, plus the ability to earn additional revenue for primary care visits, which I'll get into next. And payments in this model will be adjusted based on quality utilization, and the methodology is quite complex. Next slide. So on a high level, this is how a practice's total primary care payment is composed. So there is a population-based payment, a primary care flat visit fee, and those get summed together to come out to that total primary care payment. So the first component, which is the population-based payment, this reflects the aggregate risk score of the practice and is paid as a quarterly lump sum to the practice. There are 4 risk groups that a practice can be assigned to based on their patient population using HCC scores, and this will impact the amount that they are paid on a per beneficiary basis. So for example, A practice in risk group 1 would receive $28 per beneficiary per month, whereas a practice in risk group 4 would receive $175 per beneficiary per month. This payment will also be adjusted for leakage, which is calculated as the percentage of primary care visits that a beneficiary receives outside of the practice during a 4-quarter look-back period. In addition, practices will also earn revenue in the form of primary care flat visit fees for qualifying primary care visits. And these visit fees are paid on a flat rate of $40.82. And once the total primary care payment amount is calculated, a performance-based adjustment is then applied based on quality and utilization measures. Next slide. So this was a pretty fun visual to create, mainly because it is very much trying to condense the performance-based adjustment methodology into something that is simple and visual to convey just how this adjustment will work. So on the left side of the diagram are 2 components that must be met in order to not receive a negative payment adjustment. So a practice needs to pass minimum thresholds of the quality gateway, which consists of 5 quality and patient care metrics. And then in addition, a practice must also meet a national utilization benchmark. Practices who fail to meet these components will have up to a negative 10% payment adjustment. However, if a practice meets these 2 conditions, then on the right side of the diagram, further evaluation of the utilization measure is used to determine the positive payment adjustment. So practices will be benchmarked against other providers in their region, and also continuous improvement over time will be assessed as well. And one of the unique things of this program is that a practice can earn up to a positive 50% payment adjustment through this process. It's also worth noting that the measures in the quality gateway and the utilization measure that will be assessed will differ depending on which risk group the practice is in. So practices in risk groups 1 and 2 are assessed with an acute hospital utilization measure, whereas practices in risk groups 3 and 4 are assessed with a total per capita cost of care measure of utilization. So CMS is taking a different approach depending on what that underlying population looks like. Next slide. Now we'll switch over to Teresa.
Thank you, Alyssa. So I saw from the polling that many of you are already participating in PCF, which makes this slide perhaps reflective of your experience, but less relevant to your present decision-making process. But for those of you who are still considering about whether to join, one thing to consider is, why is this attractive? What is in it for me? Why would I join? We are hearing from our members 4 different reasons that organizations typically have chosen to join PCF. And some of these will apply to some certain organizations, other organizations, all 4 apply. The first one relates to the financial opportunity. As we just saw from Alyssa, there's a potential upside adjustment of 50% increase on the base pay, with an asymmetric downside of only negative 10%. So this type of incentive structure is really attractive for practices that are able to bear that financial risk and have a great deal of confidence in the quality of the care that they're delivering, and therefore believe that they will receive an upward adjustment under this framework. There's also the stability of the capitated revenue. And prior to the pandemic, capitation was perhaps less attractive to providers. Then we saw what happens in an environment where suddenly everything elective is canceled. Many people are avoiding care that is in person, and fee-for-service revenue disappeared for a lot of organizations. So those that were already participating in capitation found that they had a stability in their revenue that they could count on, that allowed them to keep their doors open and their lights on during the pandemic. And now, hopefully coming out the other side, that stability has an attractiveness that it may not have had before. So both the capitation as part of the underlying financial structure and the potential for upside are attractive to many primary care practices that have chosen to join PCF. The second reason relates to wanting to continue to invest in the type of high quality primary care that many of you are already delivering. We saw in the polling that most of you have some experience with this model, with models like this previously, whether that was a PCMH structure, CPC, CPC plus. Continued participation in a CMMI model allows you to continue to build upon the investments you've already made, fund the types of care delivery processes and the staffing that you have that deliver this high quality care. And that's very attractive for many current PCF participants. Tying into that is the infrastructure that supports value-based care. It's outside of the specific types of care interventions that you deliver to the patients, but it's all the things that make that possible, whether you hired more social workers or care managers. Maybe you have a new IT platform. Maybe your leadership is really bought into the concept and is prepared to support that type of financial risk and that type of investment, and you don't want to lose any of that momentum. So that's the third reason to participate. And the fourth reason is the data. You get access to data through PCF that you would not otherwise have. And it's not just the care that patients get in your office, it's everything. It's every admission, every readmission, every urgent care visit, every SNF stay, and some of the drug data, we hope. Having that full picture of what's happening with your patients provides a lot of information to help better coordinate care and to identify other quality improvement opportunities for your patient population. So that's the why behind an organizational decision to participate. What do you watch out for now that you've decided to participate, or if you do decide to participate as part of the second cohort? On the next slide, I outlined some of the potential challenges that we're hearing about from our members who are current participants. So these are not necessarily deal breakers for these organizations, but it's certainly things to keep in mind as you step into this new model. The first is the financial risk. A lot of primary care practices are really hesitant about the risks presented both by the potential negative 10% downside and by the capitated payment for primary care services. So you need to have some degree of financial stability, some degree of cushion in order to be able to bear risk under this model at all. On the other hand, you do have that upside potential, which might be very attractive. The second relates to the complexity of the quality measurement. The PCF model is unlike many value-based care models, including primary care value-based care models, but just value-based care writ large. These are outcome measures. They all are outcome measures. More traditional quality measurement under value-based care has focused on process rather than the outcome. And that's a big change in this model, and it's a change that we're increasingly seeing CMS and CMMI adopt moving forward. The quality measurement is also set up as a pass-fail metric, which again is relatively unusual in previous models. And so this pass-fail measure means that if you do not meet a minimum threshold for every single outcome measure, then you will be receiving either no adjustment or a negative 10% adjustment. And that's just a different way of thinking about quality under the PCF model. Related to that is the complexity of the timelines in this model. There are so many timelines. I've got a stack of papers printed out and I have to refer to them every time I get a question because every time horizon is different in this model. You've got the baseline period, you have the performance period, you have the time where your leakage adjustment will be measured, which is different than the time in which it will be applied. You have a rolling attribution cycle for your patients, and that moves on a quarterly basis. So the number of overlapping timelines that you have to be tracking, or that someone in the practice needs to be tracking, can get kind of exhausting and certainly takes some time to wrap your mind around. So it's not that it's a problem in terms of the way it's designed, but it certainly is an effort in terms of one's ability to understand what's going on. Then we get to the risk groups for the HCCs. As Alyssa already talked about, there are 4 HCC risk groups and there are wide payment differences between them. So depending on which risk group your average patient risk score falls into, that will be very integral to the type of payments you'll be receiving under the model. Those HCC risk scores become particularly relevant if you're right at the cusp. So if you are right at the cusp of going up into the next highest risk score, that's something you're going to want to pay attention to in terms of your total reimbursement. are there opportunities to more fully and appropriately code and document your patient's clinical complexity? Similarly, if you are at the cusp of having just gotten into a risk score, and if you were to relax some of your efforts to appropriately code and document, would you fall back into the previous risk group? Those are things you're really going to want to watch on a year-over-year basis. And then lastly, there's the definition of leakage. As Alyssa mentioned, you'll have a leakage adjustment as part of your capitated payment will be adjusted based on the proportion of your patients that are seeking primary care elsewhere. But as with many things, the devil's in the details. And so the way CMS has defined primary care is a patient that had a visit with a primary care provider that didn't happen in your physical office. For the most part, that definition works, but there are exceptions around the edges that we're concerned about. For example, what if a primary care physician is rounding in the inpatient space? That shouldn't be counted as primary care, but currently the CMS definition doesn't account for that. Or what if your patient is seen by their primary care physician as part of your practice, but you're part of a health system, and so it's a Saturday and they went to a different building? That shouldn't count as leakage. Right now it does. And so we are working, at the AAMC, we're working with CMS to highlight some of these examples where we think that the policy that they've outlined is not meeting their goals of accurately identifying what is a primary care visit that's delivered outside your practice. And we will continue to work with CMS to try to tweak some of this methodology around the edges in order to more fairly assess performance under the model. Now that I've talked a little bit about both why you might participate and what kinds of challenges you should watch out for, I'm going to turn it over to my colleague, Mandi Diamond, to talk about how you can be ready to participate in this model.
Thank you so much, Teresa. Good afternoon, everyone. Thank you for joining us today. Oh, if we could just go back one slide, I apologize. Thank you. So what we're going to do is talk about what we need to consider if we are thinking of stepping on the primary care first path. So if you embark on any transformation journey, it's always really important, like with any trip, to kind of understand where you currently are in order to know where you want to go. So what I would say is that if you are thinking of taking this path, you have to be a practice that is completely vested in patient-centered care. Really understanding care coordination, understanding using evidence-based guidelines, understanding who our panels are and meeting the patient where they are in order to increase or better our outcomes from measurement period to measurement period. PCF is really a natural progression from some of the other programs that Alyssa had brought up at the beginning of the presentation, but there are some things that we need to consider and what we could build upon from previous programs. So if we can go now to the next slide, thank you. The primary care functions that are listed here are related to PCF, and some of them look very familiar to other programs that you may have been involved with based on the polls that we saw before. So when we talk about access and continuity, we need to ensure that we're providing 24/7 access to our patients, not only in face-to-face, but also when we conduct talking with them over the phone, 24 hours a day, 7 days a week, having clinical advice available, having access via a portal, having tele-access now that has become very prevalent since the pandemic. And we want the providers that provide that access to have 24/7 access to the EMR. Care management, understanding and recognizing who our growing or rising risk patients are. As Teresa was talking about, those HCC scores are so important. And then targeting those groups in order to provide customized and very personal and collaborative care plans in order to better their outcomes. Comprehensiveness and coordination. We want a behavioral health provider within our practice to be fully integrated. We don't really want someone who's taking space where we share maybe a common work area. We're really looking for a behavioral health provider of some type to work within our practice, have warm handoffs, really be part of that care team. And not only that, we are conducting standardized screenings in order to assess patients' social and economic needs and meet them and help them achieve or overcome some barriers that they're facing. We want to be very proactive. When we talk about patient and caregiver engagement, this is when we're thinking about how we are going to assess what our patients are thinking and what their preferences are and what their suggestions are, and incorporate those ideas into our PDSA cycles. So for instance, getting qualitative and quantitative feedback. Quantitative, we may have surveys that we send out, and qualitative, we might perform interviews with our patients and their caregivers, or we might have suggestion box cards or patient advisory councils. But however we do, we need to really embrace the idea that the patient plays an integral role in creating our initiatives for improvement. And lastly, planned care and population health. We want to set goals and continuously improve. As you saw, that's a very big component of this program. We want to think about areas that we can improve upon in all clinical, cost, coordination, patient experience, and access measures. So how do we do that? Next slide, please. We want to make sure that our practice is truly embracing a culture of change management. It's very important to know that a project, this is truly not a project, because a project has a start point and it has an end point. But transformation is something that is ever evolving to really meet our patients where they are and to change as our patients and our panels change and our incentives change and the programs that we're engaged in change. So it's important to create an aim or a charter statement to assess where we currently are and what our goals are. What do we want to become? And in order to do that, we need to consider that we want to provide the right care at the right place, at the right time, by the right person, with the right quality for our patients daily. We want that to be who we are day in and day out. And to do this, we really need to consider the people, the processes, and the technologies within our organization. Next slide, please. So first, we want to discuss or think about the people. The first thing we want is leadership to walk the walk. And basically what that means is we want our leadership to walk alongside of the people that are pushing the project forward. We want their message to be clear, open communication, transparency where it's applicable, and really set the goals and tone of the project. We also want clinical champions and project champions in order to drive progress forward, to engage the team at large, and also to escalate when necessary so we don't run into any hiccups along the way. I always say when going down a transformation pathway, it's important to listen to all the subject matter experts. I've had projects where certain people were at the table at certain times and others weren't. And then unfortunately, we have to do a little backpedaling to get other suggestions involved. So it's always important to have IT, clinical, administrative, all people, leadership at the table at once. The subject matter experts are so important in understanding the day-to-day activities that take place. And it always works better to have a project done with the team and not to the team. So if they start to feel part of it, have accountability and ownership, it starts to become successful. Always pepper in change management. What's in it for me, not only as our organization, what we can flourish from, but what can the individuals on the team and our patients, what is the return on investment for them? Understand what are those boundaries or those barriers that individuals might have. What are they fearful of if we start going down this path? How can we help navigate some of those concerns and talk about it as a group? And lastly, celebrate, because there's a lot of hard work that goes into this. There's a lot of different wheels that are continually in motion. And sometimes a simple reward or a celebration for a mini milestone or a tremendous one, it goes a very long way, and motivation is a key driver. Next slide, please. We also want to talk about processes, especially in the midst of a pandemic. I work with many sites now that the root of who they are is patient-centered care. But what has happened, necessarily so, is that they've had to change or shift gears very, very quickly, be very agile based on the pandemic that we're amid at this point. So what I'm doing with many practices is we're just taking a step back and we're saying, let's do a gap analysis on what is working and what is not. It's very important to do that before you're able to move forward. Next, you want to make sure once you know what your processes are, you want to have standardization and build policies and procedures in order to state this is who we are and this is how we do things day in and day out, and use those as education and training tools. You also want to have a solid communication plan. How often you communicate, who's doing the communication, what different mediums are we using to communicate? People like to receive information in different ways. What type of meetings do we need to have? What types of communications do we need? Very important to keep the message clear and continual. We also want to make sure that our workflows are consistent, that everyone is doing the same thing throughout the organization and no assumptions are being made. And we're monitoring to always try to improve. Just because something is written or a policy is set or a workflow was created doesn't mean we're not going to revisit it if something is not working. And lastly, continual training and education to keep broadening our staff and staying ahead of the puck on what's coming next. Next slide, please. We also want to embrace technology. Technology really needs to be another member of the team. We want to make sure that what we're putting in is what we want to come out. Are we documenting in the right place to ensure that reports are giving us the information that we're craving? Are we documenting sufficiently? Is it really representing who our practices are? We also want to make sure that we are connected to the medical neighborhood. It is so important now for everyone to know where our patients are moving throughout the medical neighborhood. So using a RIO or an HIE is just an integral part of patient care. Next slide, please. I think we're actually passing it to Stephanie.
That's right. Thank you, Mandi. So at this point, we're going to move on to Q&A. I have a few questions for the panelists myself, but I would like to ask anybody in the audience, if you have any questions that you'd like to submit, you can do that in a couple of different ways. One is there is a Q&A link at the bottom as well as the chat link. So feel free to use either one of those, and we will get to them as we can. So the first question I have, I'm going to direct to Mandi. Mandi, how can an organization improve processes if they decide to join the primary care first model?
Excellent question. Very, very important. On the next slide, we have a few different workflows that should be examined. So as we said, the first thing to do is start from the beginning and truly understand your workflows at different touch points as you move that baton throughout the office and patient care. And one thing I always say here is really kind of rip down the silos, because sometimes perception is a lot different than reality. And we never want to say we think we know what the clinical team is doing, we think we know what the front end staff is doing. Really get the teams talking and mapping out those workflows and patching where there are holes. We also want to embrace the EMR. What functionalities are we using? Are there any that we haven't used? Are there any additional technologies that we need to integrate? We need to produce a training or education schedule so everyone is up to date on what the roles and responsibilities are and what the key initiatives may be. We want to analyze our reports, share them with the team. Again, that's more information that shouldn't be kept in a leadership position. We should really be sharing that information so everyone knows what the goals are and feel somewhat responsible and accountable for helping us move the needle forward. We need to adopt with tools and resources and dashboards, ways to produce and share and analyze our information and make processes as easy as possible. It's really interesting what I also say when it comes to operational opportunities. All of this is very well and good, but the most important thing is to start with that introspective look on who you are. And a lot of times I'll start with change management with clients that we work with, and I'll ask them to analyze who they are. What is their message? What do staff members think of leadership? What does leadership think of staff members? And that's so important when embarking on transformation, because we want everyone on the same team. And a lot of times practices will say that's kind of like the fluffy stuff. Let's just get to what we have to deliver. What are those final deliverables that I need to show? What are the reports? What are the statistics? So I will honor what a client wants and we'll move forward. And then when they revisit or sign with us for the following year, I'll see that a lot of those things that you see on the screen, unfortunately, have fallen through the cracks because that culture wasn't solidified. So what I would say is, yes, everything on the screen, you should be working with a consultant or with someone within your organization to strengthen, but it ultimately starts with building that spirit or that culture within your practice to truly adopt and sustain transformation.
Great. Thanks, Mandi. That was great. My next question is for Alyssa. Alyssa, what data should folks be looking to prepare for and looking at the model, and how can they analyze ongoing performance?
Thanks, Stephanie. And if we could switch to the next slide. I obviously love talking about data. And before you could even start talking about what are the metrics, I have a couple of things here, just thinking about what an organization's data strategy should be. So first and foremost, if you are in the program or thinking of joining, make sure that you complete your CMS data request and attestation form. And I always recommend, even if you don't know exactly what you may want to do with the claims data or specific files, request all possible data, especially your claims files. One of the great things about participating in these innovation center models is that you get access to data that your organization would not have otherwise. This data will cross the continuum of care. You'll see the data for what happens to your patients when they're at providers that you're not affiliated with. If they're at the hospital across the street and there's no ownership relationship, you'll still know about it. Whereas if you were just working with your internal EHR data, you might not necessarily have access to that information. So always request as much data as CMS is willing to give so that you have it as an extra tool to help support you in any type of program, whether it's primary care first or another model. Your next step is really in thinking about infrastructure. These data files are very large. You're going to need to have databases and an information technology team that can bring together this information so that it can be easily queried for information and insights. This is not going to be data that you can easily manipulate in spreadsheets. So you really need to consider having the proper infrastructure for being able to do this work, whether it's something that you have in-house or something that you decide to outsource. Which brings us to either having an internal analytics team or partners who you can work with through the analysis process. You need that capable information technology team and analysts who will be able to work with the data, who are experts in that topic. While I'm sure the clinicians and people on the operations and finance side have an interest in data and may want to dabble, they're ultimately not the people who will have all day to spend time doing that. It could detract from the other important work that they're doing. So consider having analysts who can work with this information either in-house or outsourcing it to a partner. The next thing to consider is having standard reports and also capabilities for data discovery. So there will be metrics and performance indicators that you want to track every month that will always be important to you. But at other times, you're going to need the flexibility to explore more in-depth one-off questions about your population that you may be asked on a random day and may not have been prepared for. So that data needs to be readily accessible. And you also need to plan for information dissemination to the greater PCF team at your organization. And there's no point in analyzing data if it never gets into the hand of somebody that's a decision maker or someone who can initiate change at your organization. So you should consider having regular touch points with the clinical, financial, or operational stakeholders at your organization so that you can be reviewing trends together, pointing out outliers or anomalies, and exploring other potential performance drivers. If you're thinking of specific measurements that will be important to PCF, you should consider things like monitoring the components of the total primary care payment over time. So looking at the population-based payment, looking at the flat visit fees, paying attention to things like leakage and the adjustment factors, and how that's going to impact your ongoing revenue in the program. On the topic of leakage, since the percentage can impact the amount of the population-based payment, this is a topic that you're going to want to dig into using your claims data. So being able to identify where else are your patients going to, what practices or providers, who are those patients, what are the reasons why they're seeing these other providers for primary care and not coming to your practice. You should consider segmenting your population by risk groups or risk profiles, whether you're using something like a risk score or even just breaking up your population into similar cohorts or looking at certain disease groups, like looking at your population that has diabetes, looking at your population with hypertension. And even though this is a primary care model, you should still be paying close attention to the care that's happening across the continuum, which can impact your ultimate payment adjustment because you have those utilization measures at play. So for practices in risk group 1 and 2, that's paying attention to acute hospital utilization. For practices in risk group 3 and 4, they have a total per capita cost of care component to their adjustment. So if you're thinking of what are the high cost care drivers that a person may encounter, you're going to be interested in inpatient hospital utilization, post-acute care utilization, readmissions, whether they're for preventable or not preventable conditions, really to get a handle around all of that information.
Great, thanks, Alyssa. The next question I have is for Teresa. Teresa, what other types of supports are available for folks who want to participate in primary care first?
Well, in addition to the work that Alyssa just outlined on the data analytics side, at the AAMC, we are forming a collaborative. If you'll go to the next slide, we are forming a collaborative related to the PCS model, and we are bringing together participants primarily so that you can all learn from one another. This is something that we've done for a variety of value-based care models in the past, including the PCI Advanced, the oncology care model, CJR, and the primary foundation of this collaborative is that we let organizations speak to one another about challenges that they're facing, solutions that they're trying, things that worked well, things that didn't work well. And part of the beauty of these collaboratives is that people are in different markets. This isn't your neighbor up the road necessarily. This could be someone in another state. And so there's a real frankness and collegiality that people have in collective problem solving. We also provide policy and implementation support, so explanations about what on earth CMS just released when they have another methodological document come out. We have to understand that, and also help walk through implementation steps for the care redesign that you are undergoing. We work with DataGen on the data analytics and benchmarking, and I think the benchmarking data here is really critical. CMS, in some models they have benchmarks, others they don't. When they have benchmarks, it's a year after the fact. What working with DataGen allows us to do is within this collaborative to say in a de-identified way, okay, other practices that look like you, here's how they're performing on a variety of metrics, and that can help identify opportunities for quality improvement, opportunities for increased efficiency. And not only do you see where there's an opportunity, but you can actually go talk to an organization that has done something that you want to do and learn about that. And then lastly, we advocate to CMS for changes. And in particular, we try to identify places where the methodology that CMS has designed is not serving the purpose of improving quality or reducing costs. And the leakage adjustment that I talked about a few minutes ago serves as a really good example of this. CMS doesn't want to double pay for primary care. We understand that. We want them to better define what primary care is so that they're not inappropriately penalizing practices. Other examples of things specific to this model, I think about those risk groups. There's only 4 risk groups, and there's really large payment jumps between them. What if there were 8 risk groups? What if there was more movement potentially between the risk groups? What if that were possible so that you had less of this cliff effect when you move between groups? So things like that. And we get these advocacy ideas from the members of our collaborative who are actually in the process of implementing the model. They see where there are problems. They have every intention of doing the model well, and they want to work with CMS, but they just want it to be a little bit more user-friendly. And that's where we are focusing our advocacy.
Excellent. Great. Thanks, Teresa. That's helpful. So I think that panelists have been very active in typing answers to all of the questions that have been submitted in through the Q&A bot. And I think we're running a little bit short on time. So Alyssa, do we want to move to next steps at this point?
Sure, we can do so. And we could go to the next slide. Perfect. So important dates to note. As mentioned earlier, cohort 1 is already live in the model and at risk as of January 1st. But right now, the cohort 2 provider application cycle is open. And also worth noting, CMS recently extended the application deadline by several weeks. So previously, the due date was towards the end of April. Now it has been extended through until May 21st. So there are several additional weeks in order to prepare your applications. This is also a multi-payer model. So if there are other payers that are interested in having a complementary primary care model, they also have an extended application deadline. And this will all to be going at risk as of January 1st for next year.
That's great. Fantastic. So, we're at 2:55. It looks like most of the questions, Mandi, looks like you're typing an answer to the final question, or you paused, or I don't know if that's something you want to address.
I think I had hit send on the last one that I answered.
All right. So Alyssa, I don't know if all of the panelists, all the participants can see all the Q&A, but I imagine that can be distributed at the end. I guess I'll ask any of the panelists if you have any other final thoughts for the audience listening today. I've learned a lot. It's been great. I have my own list of questions, but I'm going to hold them. All right. Well, great. So thank you all for joining us today. It's been a lot of really great information. Thank you, Alyssa. Thank you, Mandi. Thank you, Teresa. This has been fantastic. I hope everybody has a great afternoon.